Great, thank you. So I'm going to talk a little bit about some general principles to consider about rare disease diagnosis and trying to improve the diagnostic odyssey, and then zoom in on some ANA-associated diseases as an exemplar of this approach. So often the kind of solution for rare disease diagnosis has been built about genomics, but the issue with that is it forgets about the unsuspected or unrecognized patients rather than just the undiagnosed rare disease patients, the ones for whom people haven't even considered a rare disease. And then are the right patients being advanced for genomic testing? But also, there's often significant delays. So in the region where I work, there could be about a 9 to 12 month wait if you refer to clinical genetics before they're seen, and almost a 2-year wait for whole genome sequencing, so before you get a result. So you could be thinking almost a 3-year delay from the point where someone's even considered a rare disease diagnosis before they might achieve that. And also 20% of rare diseases are not genetic. So given resources are limited, and with all decisions that you make, there's an opportunity cost. If we test this patient, then the next patient is going to have to wait a little bit longer in the queue. So stratifying patients at risk, so available resources are optimally targeted, is an attractive approach. But if you're going to do this, you need to think about how you might cluster diseases at each stage of that process. So why might you want to do that? Well, we know there are often too few patients with each individual rare disease. So you can do that to increase the power for analysis, but also it's usually more helpful for the clinician. Most doctors, apart from maybe someone like Melita, who might be thinking specific syndrome, are actually thinking, do they need to be referred to genetics? Do I need to refer this patient to neurologists? Could this be a genetic form of ataxia as opposed to some other form? So how might you do this? Disease clusters that make sense. Now, these are not always in the same disease group. So it may not just be all the lysosomal storage diseases. It might be that your specific lysosomal storage disease is far more like another disease, like an ataxia. But also think about how to cluster along that pathway. So that might be along the diagnostic pathway. So how and where they present. Do they present to the GP? Do they present to a physio? Do they tend to see a podiatrist early on, like someone like FOP? Do they share the same first-line test? So do you want to cluster on that? If they're all, and that's what I'm going to talk about in a minute, or where they're referred or how they're investigated. Do they all sit on the same gene panel? Do they all get referred to the neurologist? So talking about ANA-associated diseases, so these are rare autoimmune diseases that can affect multiple organs and include lupus, Sjogren's, amongst others. I won't say them all because that uses up precious time. But they all have a diagnostic odyssey. And the ANA test is a first-line test, and that's actually quite a commonly performed test in primary care. About 2.3% of the UK population have had this test performed at some point. But many patients with a positive test have no apparent disease, at least at the time of testing, but may later develop disease. And it's unclear which of these positive patients is at greater risk of developing disease, which makes decisions about who to refer and how to follow up quite challenging and very variable. So I did some work in Nottingham where we identified factors found in the ANA-associated diseases from speaking to different people. And then we used a large primary care research data set called CPRD-ORM that's got about 11.5 million active patients, 30 million patients who've been at some point in their life in that database. And we did a cohort study looking at ANA tests, but also clustered the outcome. So rather than be bothered about single diseases, bringing all those diseases together to increase the power. So we clustered the first-line test and the outcome. So what did we find? 934,000 patients had this test in this data set. In those who are ANA positive, 14% will later develop an ANA disease. So that's the blue line there. 70% of whom are diagnosed in the first 5 years, so it gives you an idea of how long maybe you should follow these patients up. But as you can see, some patients were getting a diagnostic test coming out almost to 20 years. Being female gender, under the age of 55, and non-white ethnicity significantly increased your risk. These are hazard ratios. And certain ethnic groups were significantly increased risk. So blue is the white ethnicity, green is a South Asian ethnicity, and the red is a black Afro-Caribbean or black African ethnicity. So in summary, improving rare disease diagnosis involves thinking beyond genomics, consider the entire clinical pathway, where are the missed opportunities, Where does the disease fit along this pathway? At each point, what is the question that actually the clinician's asking? Not do they have this disease, but do I need to refer this patient, and can you help at that point? And where is the sweet spot or spots to have maximal impact in improving diagnosis? And then think, what is the optimal intervention? It might be awareness of a test, it might be an educational program, it might be something else. Thank you.